And this is sort of the main thing that we used our basis for sample size calculation. So we were able to show in this paper that firstly, they don't have great outcomes. It does improve with alteplase, but it still has phenomenal scope for improvement. Next slide, please. Okay, and early recanalization is not super high. It takes time for it to recanalize. And this was the review article that we wrote defining all the terms. Next slide, please. So jump forward, this was the trial. Our sponsors were Canadian Institutes of Health Research and Medtronic. And then obviously we had a CRO. It was an FDA approved protocol. Next slide, please. We did it in 5 countries, Hungary, Germany, UK, Canada, and US. We had 66 sites. Next slide. So as I said, 530 patients, 1:1 randomization. Next slide, please. Okay, so the inclusion criteria, we made it into a pragmatic trial that basically there had to be a medium vessel occlusion in an adult patient less than 12 hours from onset. The medium vessel occlusion should explain the patient's clinical deficit. The premorbid status should be reasonable. Any form of imaging is reasonable. No intracranial hemorrhage as is obvious. Next slide, please. And informed consent. Next slide, please. Yeah, so simple criteria, aspects more than 5, medium vessel occlusion, avoid secondary MEVOs if possible. The basal ganglia should be sort of looking good. And the team should be comfortable going after that site of occlusion. Next slide, please. The usual exclude pregnancy, exclude major comorbid illness. Next slide, please. And next slide, please. And we did anticipate some challenges. So for example, there was a lack of consistency across definition of distal occlusions, medium vessel occlusions, medium distal vessel occlusion, distal medium vessel occlusion, medium and distal vessel occlusion, medium or distal vessel occlusion. So we tried to refine it as much as possible and keep it simple. That the key factors were that it has to be at least 1 millimeter. Like I said, A2, A3, M2, M3, P2, P3. The third part was that it has to be not severely tortuous. You should feel comfortable going after it. And then the fourth part was that we were expecting that dominant M2s will not get randomized based on, firstly, our survey of the sites, as well as previous papers that we've written from Hermes. Then we were anticipating challenge also in people recognizing secondary MEVOs, especially at 2 a.m. in the middle of the night. We were also expecting this challenge of patients who present with low NIH. Is MRS good enough to be able to discriminate? And I'll talk more about it. And then we were concerned about safety, that are we going to have too many complications? And we were concerned about equipoise, whether people would randomize a 62-year-old, et cetera, but would be willing to randomize an 87-year-old. Next slide, please. So these are the kind of occlusions that we anticipated to see. Next slide, please. And this is just using multi-phase CTA to diagnose MEVO. We taught people how to use multi-phase CTA, how to use single-phase CTA, next slide, and how to use CT perfusion as a MEVO detector. Next slide, please. And we told them not to enroll secondary MEVOs. Next slide, please. So the results. So we enrolled a total of 530 patients, interim analysis at 250 for safety. There were no concerns, so trial proceeded to completion. Next slide. This is the baseline characteristics. So typical kind of stuff that you would see in a stroke trial, lots of hypertension, hyperlipidemia, typical Caucasian population based on the countries that we enrolled in. No surprises there. Next slide. And we were happy with the baseline NIH stroke scale. So median of 7 or 8, which means they were sort of moderate strokes. And as expected, most of the occlusions were M2, M3. There were hardly any A2 or A2, P2 kind of occlusions. From around 60, 55, 60% got thrombolysis, which is also an expected thing. The onset to randomization was on average around 4 hours, 4.5 hours kind of thing. Now, interestingly, I'll come back to this point. So Siddiqui 2B3 was 75.1% in this data set for the endovascular arm. So next slide, please. Sorry, Adnan, are you asking me to respond to a question? Because I'm on the phone, I can't see everything that's going on. So
I'm not. Sorry, that's for our tech support.
Oh, okay. So these are the main results. And sorry, guys, I'm again keep apologizing. I'm sort of on the phone, so I myself cannot see my own slide very well, and I don't want to go back and forth with my laptop. So these are the main results, and you can probably see it better than I can. So the result is, so to speak, completely neutral. MRS 01, 43, 41, MRS 02, 58, 54. Whichever way you look at it, it's a completely neutral result. No benefit of endovascular treatment. Next slide. And this is the adverse event rate. So no surprises here. The two things that I'll point to you is that if you look at the lowest two rows, arterial access complication, arterial injury procedural, there isn't a very high level of injury. There was all this thing about that if you go into the M3 and you're pulling the XYZ device out, will there be increased injury? And the second thing is there was increased pneumonia in the endovascular arm, possibly related to general anesthesia. So this obviously was something we were expecting. So, but the usual sort of standard complications. Next slide, please. And again, from the point of view of symptomatic intracranial hemorrhage or intracranial hemorrhage, you can see that they're slightly higher in the EVT arm, which is again expected. And if you see the lowermost row over here, there was increased subarachnoid hemorrhage. And this is that hyperdensity very often you see after you pull clot out from an M3. But most often it was not clinically significant. So it was there, but not clinically significant. Next slide, please. And this is the Grotta bar. So again, as you can see, sort of completely neutral trial. Next slide. And this is the mortality thing. So slightly increased mortality in the EVT arm. Next slide. And these are all the subgroups. So again, as you can see, pretty much all subgroups are kind of neutral, very different from the LVO thing. At the left lower corner, you can see there's some degree of sort of benefit in the early patients and the harm in the late patients. Now, obviously, one of the things I want to point out is you slice it, dice it 20 different ways. One of them randomly will come out showing some signal. So that's something to be cognizant of. This, to some extent, was a little bit counterintuitive to me because like the early patients were the one who got the TNK TPA. So I would have thought that the effect of EVT would be less in the early patients. So it didn't sort of totally make sense to me. But at the same time, it is what it is, and this is worth exploring. So we're looking at this in detail now. Next slide, please. So basically, the conclusion was in acute ischemic stroke due to medium vessel occlusion up to 12 hours, EVT did not show any benefit. Next slide. And then in parallel, this is the New England Journal paper. Next slide, please. So in parallel, the Distal trial was very similar population size. Next slide. And this was published in AJM. So very similar results in terms of showing lack of benefit of EVT. Next slide. And this is their overall sort of results. So as you can see, again, exceedingly similar in terms of sort of MRS 01, ours was whatever, 43, 41. Theirs is 35, 37. Next slide, please. And these are the subgroups. So again, very similar, that all the subgroups which we looked at were similar to what they looked at, kind of thing. So again, a very similar result. Next slide. And their paper was also published in the same issue of NEJM. Next slide. And then there is the discount study. The preliminary results were presented by Fred Glenson from Paris. Next slide. So 488 patients were planned, but they stopped early. Next slide. Next slide. And next slide. And they used a whole bunch of different devices, so similar to sort of what was done in Distal as well. Next slide. And there was sort of a distribution between aspiration and stent retrievers. Next slide. So next slide. So they had 163 patients randomized at the time of this presentation. They were still waiting for a few follow-ups. Next slide. Next slide. And this is typical. Next slide. Next slide. Or they have all these. Next slide.
Yeah.
So they had aspiration and stent retrievers both used in the trial. Next slide. And this is the main result. So basically, they showed that there was harm in EVT. So the control arm at 77% MRS 2 or less, and as opposed to 60%. And this was statistically significant. Next slide. Next. So basically, that was stopped at interim, and there is the potential of harm. Obviously, we're waiting to see their final publication. They're in the works of that paper as well. There is a Chinese trial that has finished enrolling as well. We should hopefully see the results of that in the near future. Next slide. So, and then I'll just briefly talk about what our thoughts are and then hand it over to Adnan. Next slide. Next slide. Okay, so go one previous, please. One previous, please. So are MeVos different? Is the possibility of collaterals or keeping the brain alive, is that different than an earlier time window? These are thoughts we are having. I'm not convinced that they are necessarily different, because if they were different, we would have shown clear changes at 7 hours on the non-contrast CT if they were truly sort of end arteries. But that is something we're thinking about, that for MEVOs, in fact, do we need to move even faster than what we did for LVOs? And obviously for MEVOs, we did move slower compared to Hermes. Part of it being they're more complicated, part of being need for general anesthesia, part of it being we were really pushing for speed in those days kind of thing. Then could the quality of recanalization be better in the future? So next slide, please. So if you look at the recanalization here, so like the reality is we did have substantial number of TICI 2C3. And we did tell our centers that rather leave it alone than to have a perforation. So one of the things to remember is this is TICI 2B3, the MEVO TICI 2B3 of 75%. Let's say you say we're going to do another trial with 95%. And my concern would be, will that increase the complication rate because people are pushing too hard to try to get to it, sort of thing. Next slide. And the other part that is there is this is now taking only the TICI 2C3 patients. And even then there is no signal. So this is something to be careful about, that, let us say we take, and this was substantial number of patients, it's not very small number of patients, sort of thing. And even if you look at their final infarct volume, there is no sort of significant difference either. So we have two parameters of looking at TICI 2C3. So yes, we would like to jump from 75% to 95%, but that may not be the magic here, sort of thing, based on this data that we have, and something we have to be cognizant of, and be cognizant of the fact that if we push really hard for 95% TICI 2C3, will we increase our complication rate? Next slide, please. And then going back to, was there sufficient equipoise in the community? And that unfortunately is not very easy to measure. But I do think that was an issue in many different centers across, and having discussions with the Distal group as well. For example, we had a site that was live for 14 months and did not enroll a single patient, even though they were doing 250 thrombectomies a year. So how is that even possible, kind of thing? So, and do we have equipoise? Do we not have equipoise? We obviously interviewed everyone. We had everyone fill in selection, site selection, did the SIB, looked them in the eye, and so on and so forth. But I do think there are multiple problems with equipoise. One is what you say in a cold kind of this thing in terms of talking over Zoom or talking over coffee is different from facing the patient at 2 a.m. kind of thing. And then there is this other problem that there may be the PI whom you're talking to at the site, but there are 5 other people who are there actually doing the work kind of thing. So has everyone bought into it?
I want to, I just want to, this is great. I do want to kind of double click on that for 1 minute, this concept of equipoise, because I feel like this is one of the gorillas in the room. And this is something that you were very, very transparent about with all, centers that were potentially enrolling patients, even as early as ISC in 2023, this concept of, call it cherry picking or treating patients outside of the trial, and on the converse, including patients that we may have, a high level center might just leave alone. I do know that Escape MEVO did not include screening logs, and Distal, I believe, does include screening logs. My question to you is there any way to truly objectively measure whether this phenomenon was actually happening, other than your anecdotal conversations with site investigators? Is there my first question is there any way to objectively measure if that was happening, and if so, which direction was it skewed? Were people treating that 45-year-old with an NIH of 10 outside of the trial, more so than including the 80-year-old with an NIH of 4 in the trial? So that was my first question. And then I guess my next follow-up question is there any way to police against that phenomenon going forward in the future, or is history doomed to repeat itself? I guess those are my two kind of overall questions for you.
So a couple of thoughts. One is we don't have a precise answer to that question. Second is there is always some degree of cherry picking in a surgical trial. The third thing is I call this phenomenon the waifu phenomenon. What's in it for us? And I do think we have to be more cognizant of being able to answer this question adequately for the other 4 people at the center who are not the PIs. What's in it for them, kind of thing. And I've written about this. It should get published in Stroke shortly. The fourth thing is that we are doing a study in Alberta where what we've done is we've gathered all the CT angiograms done for purposes of stroke all across the province of Alberta. And then we'll see how many of them had a medium vessel occlusion that fitted the criteria, and then how many of them were not included, and what were the reasons for it, kind of thing. But mind you, though, Alberta is the unique example because, like, we were pretty motivated being the PIs and all kinds of things, so it may not be representative, kind of thing. The last part I want to say is that in terms of history repeating itself, there are two issues here. One is that the fact that now there should be increased equipoise, sort of going back to 2013 when IMS3 results were presented, kind of thing. So that is one thing that should be there. The second thing that is there is that what can we do to, so to speak, be more inclusive and encouraging and so on and so forth with all the sites there. And the third thing is, I guess the days of low-hanging fruit are gone. To expect a 15% effect size, 12% effect size are gone. So we've got to do trials which are relatively massive by the standards of what we've been doing, like 2,000 patient trials, 2,500 patients trial, which are still above the MCID, but are still sort of big enough to be able to pick up those effect sizes. So that's sort of my short answer. I don't have a precise quantification of the degree of cherry picking. So
your first comment being that now, if you were to say repeat a trial such as this, investigators might actually have objective data to suggest, oh, there is actually equipoise, and therefore might be more willing to truly randomize in a one-to-one fashion. Is that what you're implying?
That's what I'm really hoping for. But at the same time, that comes to the next point in that list. Are there subgroups based on NIHSS, for example, more severe strokes? So I've been asking people verbally, including people like you, 63-year-old M2 occlusion, non-dominant M2, NIH of 12, 3 hours from onset, right? And it's a straight vessel and you think you can easily get there, kind of thing. So what's your willingness to randomize? And then again, I stress this point that when I talk to people and people say, yeah, I'm willing to randomize. But what happens is when you're right in front of the patient and patient's family, does that change your mind, kind of thing, right? So there's that other issue as well, kind of thing. And then depending, as we all know, that the process of taking consent in these situations is sort of not easy, because what happens is the patient families ask you, what would you do if this was your whatever sort of thing, right? So so when we were running escape trial, SWIFT prime trial, I used to train people on how to answer that question, sort of thing. So just to move on, then the other issue that we've been working with is that this whole idea of MRS. So if the person has an NIH of 4, is MRS the right outcome measure? And I've been working on this for 3-4 years, and finally we finalized. Next slide, please. So we've been working on this. This should come out in stroke next week. Next slide. So we call it the Cosmos scale, Canadian outcome score for minor stroke. I won't spend much time on it. I want to quickly hand over to Adnan, but this is a scale that we've specifically created for this purpose, sort of up to the NIH 6, 7 kind of thing. So the way to think about it is, 1, we expanded MRS 0 into a 6-point scale, and 2, we made it much more patient-centric. For example, I love to play piano, but I can't play piano anymore. I love to look after my grandkids, but I can't look after my grandkids anymore. And how does that influence outcome measures? So we made it more patient-centric kind of thing. This is imminently going to get published in Stroke. We just did the proofs kind of thing. So it should come out next week or next to next week. And we already have a lot of interest in this. And we did, the next slide, please. We did a lot of inter and intra-observer work here in Canada. So it's already, we found that it's quite easy to do and people are finding it intuitively sort of obvious. So we're already starting to think in terms of solutions to the problem. Next slide, please. I think that's probably the last slide. Yeah. So, and as always, you present this work, you stand on podium, so on and so forth. There's zillion people in the background who are super involved that we have to be thankful to, including our sites and all. 2 specific people I would like to mention is my dear colleague, friend for many years, Michael Hill. And then my mentee fellow, Johanna Ospel. Without those 2, this would have been impossible to do. So thank you so much.
Thank you, Mayank. To go to that Cosmos, that scoring system, I think most of us who study this disease are well aware of the shortcomings of the modified Rankin score, and the fact that it's simply not eloquent enough to pick up insults of these medium distal vessel occlusions. It's very heavily weighted towards motor function. It doesn't take into account cognitive scoring. With this Cosmos score, do you think that there is a greater onus for other scoring systems in these trials going forward? How do you feel about other scoring systems based on imaging, say, CT perfusion or Delta NIH stroke scores, like in the in the Distal trial. What are your thoughts on these?
I don't think any imaging outcome is going to work. It has to be a clinical outcome. So it has to be a clinical outcome. Imaging outcomes, we've written enough papers on this and also, frankly speaking, we don't even understand imaging, and we've written on this. We don't even understand how to measure final infarct volume. We don't understand what is likely diffusion, heavily diffusion, what is core, so on and so forth. We've just submitted a paper from the Aurora database that there is a discrepancy between final infarct volume between control and treatment arm versus clinical outcome. We wrote that from Hermes as well. The imaging based is able to explain the clinical outcome only by 12%. Miral Bors from Netherlands had led that paper. So it will not be an imaging based outcome. Whether Delta NIH, that's a good one. We've written papers in terms of importance of correlation between NIH and MRS kind of thing. The third thing that is there, Krishna, is that I do think whatever we may use, we cannot overnight jump onto it. We have to have its validation. We have to go through the sweat process and show it across multiple trials, multiple this thing. And I've been saying this in my talks that whatever scoring system we have to sort of start using it as a secondary outcome, validate it over the next few years, and then make, so to speak, a case for why that could move over to a primary outcome. It is in no way that we can randomly decide, okay, Delta NH or Cosmos or whatever can be the primary outcome, but we have to start collecting that data.
Do you see a future where the FDA or where committee guidelines are actually basing their recommendations on these secondary scores like Cosmos, like the Montreal Cognitive Score, like Delta NIH, like?
I see it as an absolute necessity as we move towards relatively minor populations kind of thing. I'm not suggesting the Cosmos is the be all and end all. Obviously, I have my own bias because I've been thinking about a problem for 3-4 years, and finally we've done the work and sort of publishing it next week kind of thing. But I would strongly encourage other people who are listening to this, smart young people and stuff like that, and whatever you may do, it'll take you 5 years to validate it and to pick it up kind of thing. So you have to start somewhere. You got to start now. And hopefully by 5 years from now, we are able to show it in a bunch of trials that it actually matches what patients want. And we've done patient interviews to create this score as well and realized what are the things that are important to patients. So we made much more kind of patient-centric when we did this. So.
We have I was monitoring your slides, but we have a couple of good questions from the audience. One is on technique. The question was, what percentage of discount patients were treated with aspiration? I think we'll get to the technique with Dr. Siddiqui's presentation.
So in Escape Mevo, first attempt was with solitary device.
Yeah.
And in discount, there is a slide over there. I don't know the details. Remember, the sample size is pretty small. This is their interim results. There were only 58 patients. I think out of those 60% or so were stent retriever, 40% were aspiration. Generally, these are not just from the top of my head kind of thing. So, but they will get published soon. So.
Thanks. Dr. Milburn, is there a subset analysis for patients who received perfusion and had a favorable profile?
Yes, we are doing that right now. We do have substantial number of patients who had perfusion, and all I can say is nearly everyone had a favorable profile. Well, obviously, James, it's also dependent on how you define favorable profile, but all of them had sort of penumbra.
Dr. Siddiqui, do you want to start presenting, and we can kind of have an overall discussion at the very end? I think you're muted, Adnan.
All right, so I think the introduction to the topic has been very well covered by Mayank, and so I don't need to belabor that. But what I'm going to do is just quickly skip over some data. Can you hear me okay now?
Yes.
Okay. So here are my disclosures. I'd point out two things. I have significant conflict with both imperative care and rapid medical. I serve as a consultant, and I have some stock in imperative care. So you should take what I say with a pint of salt. So we're talking about DEVOs and MEVOs here, and we briefly covered some of these trials. Mayank covered very nicely that these are supposed to be significant population of patients compared to all the other etiologies that cause stroke. And many times because of the affection of eloquent territories, there can be issues that impact things such as detectable by something like the Cosmos scale. There is a specific indication for IV-TPA for these MEVOs, but there are issues with IV-TPA for MEVOs, as were nicely covered. And these are, again, Mayank's papers, which clearly demonstrate that almost 50% of patients do not achieve recanalization with TPA alone. And when you look at the disability rate for patients, it's still significant. So when you look at suboptimal outcomes, death or disability is almost 50%. And MRS of 2 to 6 and MRS of 3 to 6 is a third of patients are significantly disabled. So there is desire to change the outcome of these patients, and that led to these multiple trials. We also sort of understand with other trials like the Stop Strokes study, again, suggested similar numbers of significant disability. And when you scan the literature, there appear to be significant number of studies that seem to suggest that there is benefit. So I think there was a real equipoise in the community to support these trials, the MEVO trials. And now MEVOs are unique because of two particular features compared to LVOs. One is that they are smaller vessels, and so that is something to keep in mind, very important. And the second is they tend to be a little more fragile in terms of tortuosity and anchoring into the subarachnoid space compared to, say, the internal carotid or MCA or vertebrobasilar, because they tend to be thicker adventitia and more tethered to the adjacent dura compared to MEVOs. And then Mayank covered the two types, the primary, that's what we're talking about. Although the majority of cases outside of clinical trials are typically dealing with secondary, this remains a significant problem. Secondary clearly has been shown to be worse than sort of primary. So 3 trials have been presented, 2 with peer-reviewed publications, Distal and Escape MEVO, that were shared by Mayank. Discount, we just saw the abstract, and we saw some additional data by Mayank right now from Frederic, and that's useful. And there's one trial which is still ongoing, and that is with a uniquely designed stent retriever specifically for MEVO vessels, which is the Distal's trial using the Tiger retriever. And the Tiger retriever is something that comes in different sizes, but the one that particularly is interested in the distals, it goes through a 13 microcatheter, really designed to not overexpand vessels, such as happens with stent retrievers. So I think this remains, it's ongoing, it's enrolling, and I think it would be really interesting to see that if the results might be different with a specifically designed stent retriever for DEVOs. So the consensus statement is there was no particular benefit. We already heard about it. And there was some concern that there was a high mortality in the group. But the issues that remain are that patients in these trials ended up being much older than other average thrombectomy trials, raising concern that maybe people were inclined to treat younger patients outside of trial. We also noted the average NIH dropped significantly from the teens down to 5 or 6, which again suggests that maybe patients were treating out of trial patients with significant NIH deficits. So I think those were clearly concerns that one can sort of anticipate. And Krishna, you asked the question, can we prove that? I don't know. Maybe we can. So with that
trend, Adnan, I know that was happening in Distal, this trend of dropping NIH and increasing age. Was that trend also present in the discount trial?
And we have very little information about discount trial, very small number, and all we have are a few slides from the presentation. So I don't know if we can really answer that question. But the
Mayank, was that trend?
Escape MEVO and
Distal
both had much lower average NIH compared to prior stroke trials. And that was not evident that much when you're looking at the MEVO data from non-randomized trial cohorts that were previously presented. So with that backdrop, I would like to sort of talk a little bit about the imperative care trial. This was using the entire spectrum of the Zoom catheters from Zoom 35 all the way to Zoom 88 and the pump to see if we could achieve revascularization using the old category of NRY, which is ICA, M1, M2, basilar, and vertebrals within 8 hours of symptom onset. So this was not a 24-hour trial. This was not just an interior circulation trial. This was a global circulation and prior to less than 8 hours. The standard endpoints were MRS, 90 days, and there was independent core lab, there was independent data safety monitoring board, and an independent steering committee with 260 patients enrolled, including 211 concomitant aspiration cohort. So overall results of the trial were quite impressive, as has been noted with some of the other the single-arm studies, with an 87% Siddiqui 2B or greater result, with a rescue device rate of only 4.7%, meaning requiring some other device not made by imperative, including stent retrievers. So that number was a lot lower than, say, in Compass, which was the prior randomized trial with aspiration with stent retriever, where that number was almost 15 to 20%. This was a lot lower in this trial. And again, serious vessel injury was very low with a symptomatic ICH rate of only 0.9%. Again, these were independently core lab adjudicated, and here you can see a 71 catheter sitting in the occlusion site, and now 88 going all the way up there. So aspiration can be applied first through 71 and then through 88 as well, which was done in a large number of cases. A few things that came out of the trial: the revascularization time, which is groin to greater than Siddiqui 2B, was 19 minutes. So when you compare it to other prior trials, it looks like we are getting faster, or this technology is getting better that allows us to achieve adequate revascularization in a faster fashion. We also sort of measured the anatomies that we're dealing with, because as you well know, these patients tend to have more tortuous anatomy. So Max Smokin did a paper some years ago where he measured 100 consecutive stroke patients and noted about 15% had type 3 arch, again, meaning a more complicated procedure. And when you look at the numbers from the imperative trial, looks like we were dealing with not cherry-pick cases, but standard difficulty with stroke patients. So I think that is an important thing to keep in mind. In terms of the data, what I've done here is really put together on one sheet. So you can, I don't have discount data, so I could not really incorporate that in this slide because it doesn't have a publication yet. But if you look at the age, again, the age was much higher with both escape and with distal, and imperative care is more traditional in the mid to late 60s. The number of African-American patients was a lot higher, and I understand distal was Europe, so I get that, but escape was more North America, and again, imperative would suggest that we had a more real-world population. Baseline NIH, again, is reflective of a higher NIH in the imperative trial, but again, remember these numbers, we are not looking at the overall cohort of the imperative patients of 260. We're just looking at the M2s, which were 65. So I think that's an important thing to keep in mind. And when you look at time to last well known, it was a little higher with distal and lower with escape MEVO, because you had Mayank, who is about as good as workflow gurus come. They really wanted to make sure these trials are done in a timely fashion, and imperative lands right in that range in the middle of them. And again, about 43% had atrial fibrillation, which is a little higher than the other trials, but is associated with embolic disease. In terms of the key results, the revascularization rate in the interventional arm for escape was 75, for distal was 71, and with imperative, again, the M2 cohort was 87%. So there seems to be better revascularization in this non-randomized comparison. The symptomatic hemorrhage rate a lot lower, 5.4 to 1.5. I think that's a significant sort of value to reducing the number of stent retrievers in these distal, fragile, tortuous vessels. Serious adverse events were quite similar in all the different trials. And then when you look at the MRS of 0 to 2, which is probably not the best scale for MeVos, but again, was at least as good, if not numerically slightly better. But if we actually focus on MRS of 0 to 1, which is the desired goal in this population, there is a significant difference. And here what we have done is we have also added the best medical therapy cohort for both escape and distal. And you can see the numbers were slightly better with escape, 41 versus 43%, not different, and 34 versus 37%, again, not different, but they were 55% with the imperative M2 cohort. So again, suggesting that there may be something special about aspiration that was not well appreciated in these other trials, which were predominantly done with stent retrievers. So I'm going to quickly show a standard case of a young patient. This is a hemispheric deficit, and it looks like there may be an intracranial distal ICA occlusion. The access is established with the VTK catheter, and we start off by creating an ICA aspiration with 71 followed by 88. There's the 88. You can see there's some delayed filling suggesting there's a supraclinoidal occlusion. And here now 71 is being pushed all the way into the MCA and retracted into the 88. And that results in revascularization, which is considered adequate with minimal deficit. Now,
sorry to interrupt. In terms of the M2s, are they defined the same in the 3 different studies that you're referencing?
So M2s were easy to define in the imperative care trial because they were all M2s.
All M2s, yeah. So the dominant M2s were not considered an LVO?
No.
Okay.
Not for imperative, but there was differentiation in MEVO and distals, and Mayank can speak more to it.
Exactly. I think that's just an important...
Yeah, but one thing to point out, though, that the median NIH was 13. So when you have a median NIH of 13, they're likely to be sort of bigger M2s.
Exactly.
Right. Like the reality is most people were not willing to randomize an NIH of 13 into these trials. So.
Yeah.
I think
so it's apples and oranges sort of thing, right?
Totally. Thank you.
So this is a 70-year-old NIH of 14, and again, primarily because of paracentral region missing. I think perfusion helps, and you can sort of see this is an M3, which is occluded, and so you are now going here with an 88, and through that, we're using a Zoom 55, and that's driven as high up as it would go, and then aspiration is applied. And there you can see the 88 tracks all the way to the MCA. The unique advantage here is that when you're putting it in 88 into the MCA, you're creating the same effect as a balloon guide catheter in the neck with flow arrest because of the large vessel and the aspiration. And then we pull it back till we get blood flow back, and then we do a run. And now what we see in this case is that there is the occlusion has moved a little bit distal. So again, having the value of a system approach, now you're going up with a 45 catheter, and you can see the 45 catheter go all the way up there. And again, the same thing happens with TrackStar, tracking down the aspiration and creating the local flow arrest. And again, we sort of move to a little bit more distal. There you can see now it's really the terminal. I would say it's M5. But we really believe that we are trying to solve a central artery issue. And so we continue, and now we go with a 35 all the way up there, and then pull that back. And that is what gives us the final really good result, which is this artery is open all the way to the terminal segment. There you can see it. And that results in an NIH improvement of NIH 13 to 1. So I think the value here is that you have a system approach, and you can go from small to large all with the same technique. And I think there appears to be significant suggestion that there is value here. But I want to talk about one more quick thing, which is a new iteration of technology that is being brought about by Imperative, which is this continuous dual aspiration technique, which is where you apply aspiration with the pump to both the guide catheter as well as the aspiration catheter. Because normally when you're applying pump aspiration, somebody else is doing it with a manual syringe. And here's an example of that. With the manual syringe, there's an M1 clot. This is obviously in vitro. Once the clot is engaged, we apply the locking syringe to apply vacuum and then pull the clot into the 88. But the moment the clot comes out, the aspiration is lost and the clot is lost. And I think if you switched it around, again, same clot, but this time you have dual aspiration from both the guide catheter and the aspiration catheter. You don't lose the clot because you have continuous aspiration of 88 as well, and that results in ingestion. So we believe that might be a unique value going forward. And I'll end with announcement that just came out yesterday, I believe, that Imperative Care wants to do a randomized trial of M2 occlusions. It's going to be randomized 1-to-1 and will compare aspiration thrombectomy to best medical therapy. It's going to be led by Adam Arthur, and the primary efficacy at this point, till we get Cosmos up and running, I think I'm really excited about that scale, is going to be the modified MRS at this point. And I thank you very much.
Awesome.
Great. Thank you, Adnan. I want to talk a little bit about technique just because of Dr. Siddiqui's presentation. One of the issues with the distal and the discount and perhaps even with the Escape Mevo is these, early generation aspiration catheters. And now with Imperative Care and other, these other distal, lower profile, longer aspiration catheters coming out, the game has changed. The 3 max and the 4 max catheters that were used previously are simply not on the shelf in many places. Mayank, my question to you, in terms of technique, do you have any sense of what patients necessarily perhaps failed with the first pass solitaire and then subsequently went on to recanalization with an aspiration technique? Do you have any sense of?
So one of the things that is there is we talk about devices, but we don't talk about who's operating, right? So remember, if you do a trial, 66 sites, five interventionists per site, you're dealing with 300 people. So not everyone is going to be an Adnan and going from 71 to 45 to 43 to 21 to 17 to M5 to M6 to going into the capillary kind of thing. So you just have to be sort of cognizant of that. The reality of it is it was 75% here and 87% there. So one thing just to be sort of absolutely clear, and I showed data on that, is that let us say hypothetically you repeat the trial, 530 patients, everything else remains the same. You jump from 75 to 87, it's not going to result in a positive trial. So you need a much bigger trial. You need other things that you need to think about, including cherry picking kind of thing. So all these advances are great, and we've always known that things work out differently in a randomized trial compared to a single arm trial. There are many more operators, et cetera, kind of thing. And obviously, there is the part about the device, and there's the part about the operator as well, which one has to kind of keep in mind. So we are slowly improving, as you know, going back to sort of 2013, 2014, and all that kind of stuff. And we continue to improve, which is kind of great. And we have many more choices available. And it's great that Imperative is putting it into a randomized trial kind of thing. And one thing that is there, we did a sort of, I called up probably 50 people and say, are you willing to randomize a dominant M2? And I would say 49 people said they're not. So that's the other thing to be sort of cognizant of, that there are different kinds of M2s as well. So I think I'm hoping that as a consequence of these 3 trials, there is increased willingness to randomize, but I'm not totally sure. People talk the talk, but sometimes sort of are not able to walk the walk. And I can completely understand that. I face that as well, that, you're in front of the patient's family, so on and so forth. And your body language is, oh yeah, I can open this in 11 minutes kind of thing and stuff. And so it's not easy.
And that certainly is one of the issues with just talking about definitions. You know, the escape mevo definition of an M2 is different from the discount definition of an M2, M3. Adnan, where does imperative care trial kind of lie in that spectrum of definition? Is there an objective definition of how the M2, M3 was defined? Is it the vertical segment? Is it the horizontal segment? How does imperative care define its anatomy?
So because this announcement is super, super recent, all I can tell you is that there's a desire on the part of imperative care to follow in quick succession with aspiration. But these are the kinds of questions that Adam Arthur and others who are leading the trial will have to decide, because we don't want to be in the same quagmire as the first round because people completely decided to exclude dominant M2s and, as Bree suggested, just treated them as LVOs, which is in reality what happens. So one way to deal with that is to have all M2s, and that's the simpler approach, but probably more likely to result in selection bias. Or the other approach is to not treat the dominant but only non-dominant M2s. I do agree with their strategy of not putting everything into the MEVO basket, because that's another thing that we've sort of learned, that it's really hard to compare P2s and 3s and 4s to A2s and 3s and 4s to M2s and 3s and 4s. So I think those trials are deserving of being done, but they probably should be done amongst themselves. So I think it would be great to have a P2, 3, 4 trial with a different strategy, an A2, 3, 4 trial with a different strategy, rather than putting them all or lumping them all. So I agree with the M2 strategy, but whether it's a hyperdominant or codominant or non-dominant, we have to wait and see.
Mayank, I know that the ACAs and the PCAs were, I think, 10 and 5% of your total cohort. Was there any signal or trend to suggest that there was a subgroup analysis benefit of, you know, only MCAs? And did you ever consider that, isolating it to MCAs and looking at those alone and excluding ACAs, PCAs? We know that ICAD is very prevalent in these lesions.
Yeah, so we looked at the subgroup of MCAs, and there is no signal there. But our plan is to merge all the 3 trials and possibly a 4th one, and then we may have enough sample to look at the ACAs and the PCAs. So that's part of the plan. We are already in conversation with Mario, Zors, Fred, and then, like I told you, Oriental MEVO is just finishing, and we'll have conversations with them as well. I do think, though, that for example, if there was a P2 occlusion with hemianopsia, and they can very often on an MRS, it may be very difficult to pick up the benefit of treatment, but that'll get picked up in Cosmos sort of thing. So that's one of the thought processes we had. Similarly, a distal ACA can lead to slight change in personality, slight reduction of motivation kind of thing. So for example, recently I had a patient who was like a grandmom who loved looking after the grandchild, but after an ACA stroke was unable to do that. So we're hoping that that will get captured in Cosmos, but not in MRS. One thing I do want to repeat myself to say, that this idea of MCID, minimal clinically important difference, right? So what's the difference that makes it the whole thing worthwhile kind of thing? And, you know, different people have followed different techniques. What I did probably 10 years ago was I just interviewed people, and people liked the figure 5%, and people said, if there's a 5% improvement, then that's good enough for me in the MRS, and we'll start doing it kind of thing. Jeff Saver published a paper of 1.7%. He thought, based on his analysis, it was 1.7%. And MCID is complicated. You ask the patient, you ask the patient's family, you ask the doctor, you ask the resident, you ask the professor, you ask the administrator, you ask the person who controls the hospital budget. Each one of them will have a different answer to it. But let's say, for the sake of argument, for the current, this thing is that 5% is good enough for us, then we should design a trial that is capable of picking up a difference of 5.1%, which is practically 2,200 patients kind of thing. So I don't think we can run away from the idea and of doing 500 patient trials. And, you know, you go back to 2015, Bruce Campbell did a trial of, I don't know, 71 or 75 or 81 patients or so, something like that. And that was a positive trial. So those days are gone. The low-hanging fruit is all gone. So
One interesting point from the imperative data was around the safety. And as an operator who, you always want safety to be number one, especially when you're going after something distal. Do you think there will be a shift toward aspiration? I think as an operator, I feel that it is safer, in going after smaller vessels. Is there any data that we're going to see to support that aspiration versus stent retriever, aspiration superior?
Well, I think like there is this part about intracranial hemorrhage,
Yes.
hemorrhagic transformation versus, so to speak, shitting the fan kind of thing, right? So I do think they're different. So
Yes.
I think we sometimes conflate different terminology and we lump it all into sort of one. So that's one part. The second part that is there is that there is a natural evolution of hemorrhagic transformation in a certain percentage of infarcts, which is not in any way, shape, or form a complication. Third is it is dependent on the modality that you look at, MR versus CT. The fourth part is once we have a merged data between distal and discount, there are quite a few patients who had aspiration. So I do think we'll be able to write a paper on stent retriever versus aspiration and at least show you. Now, obviously, there's always this argument is my device is better than your device kind of argument, sort of thing. That's an unlimited thing in our field. So that will continue, and that is good in a way because it forces us to sort of do better and better and better kind of thing. So that's all great. So I do think we'll be able to answer some of these questions, maybe not to everyone's satisfaction, but we will be able to answer them. I do think overall, bad complication rate in all the three trials was quite low.
Yeah.
Yeah.
I think you bring up an important point there, Mayank, in that, there will always be this competition of, which device is better, which technique is better. The underlying fact is that, technical differences need to be measured by technical metrics. And unfortunately, as you have pointed out, the modified Rankin score is simply not sensitive enough to pick up granular differences in these techniques, in these devices. And there really is a great need for another biomarker of not only safety and efficiency, but also, superiority. And I certainly hope something like Cosmos and these other scores like the Montreal Cognition Score or even patient-reported outcome measures can potentially pick up those subtle differences.
I think from the way I look at the data, there is a real concern of using the MRS as the yardstick. There's no question about it. But I also feel that we may need some more specific scales for PCA compared to, say, ACA, compared to, say, MCA. That, again, we'll need the validation. Mayank pointed this out, that we need to do the hard work to validate these assessments. I think Cosmos is a step in the right direction, but it still tries to have one scale for all of them. And really, these patients are so different that it's kind of hard to put them all. So I do feel that there's a real need to come up with alternative scales. And as these trials are getting designed, this is an excellent opportunity to prospectively collect the data so we can validate some of these scales as an outcome from the trials.
I want to get to some of these questions that we have not been able to answer. Is there a role for antiplatelets or thrombolytics in medium vessel occlusions?
I'm not sure we can sort of suggest them. I think there is clearly the value of thrombolytic therapy. That is definitely there. Even though it's not perfect, it is better. I don't know, Mayank, if you have specific data on MeVos and TNK or some of these newer agents, but antiplatelet therapy is really reserved at this point for ICAD and those causes. I also feel that the trials that have used 2B3 inhibitors and other antiplatelet agents haven't really shown the kind of effect that we were hoping for. So I think we're limited to thrombolytic therapy right now.
there is this talk about intra-arterial thrombolytic therapy, and there's been a revival of interest based on the recent Chinese trials that were presented. And I've had at least 5 emails or WhatsApp messages. What do you think about doing a randomized trial of IA, TNK versus control arm kind of thing? And I do think, again, like people seem to be in a hurry to sort of jump the gun kind of thing, but it's possible as we go through it in the future over years, that for the M3s we go more towards IATNK, and towards M2 we go more towards sort of the traditional mechanical kind of thing. So it's possible that we may go in that direction, but I still find it hard to imagine that there's something that's sitting in the atrial appendage for 10 years, goes up, blocks in the M3, and IATNK is going to solve it, sort of thing. The other problem that I have with IATNK is that I do think there is this issue of where do you put the microcatheter when you give it. And in some of the Chinese trials, it was put in the M1, and I just don't see how you give TNK in M1, it goes to the blocked M3. Most of it will go into all the other open vessels, which means then you go into the M3. And if you go into the M3, then there's this issue of, oh, I'm right there. Why don't I just suck it out kind of thing? And why do I sort of futz around with IATNK? So there's all these issues that we have to sort of sort out. We can do them in imagination, but I do think, though, one of the things that I've realized over 12 years of sort of doing this is that you got to pound the pavement and really be working with people collectively in terms of that who walk the walk. And that is going to be our single biggest struggle, is that we all have to collectively walk the walk.
Michael Abraham had a very interesting question early on for you, Mayank. What dialogue did you teach your team to use for the ESCAPE trial? These are very difficult conversations at 2 a.m. to randomize these patients. What, again, you were very, very transparent early on in this trial. But what tricks or pearls did you use for these site investigators to have these conversations?
The original ESCAPE trial in like 2013?
No, ESCAPE Mevo.
No, ESCAPE Mevo, like in terms of sort of like basically that if you want to know the patient comes in and all that kind of stuff as an NIH of 7, then the typical conversation we were having, which I'm sure many other people can sort of attest to, is that the conversation was that we did these trials 10 years ago that showed benefit of LVO. This is a smaller vessel. It's potentially less safe. It has potentially less benefit. Even thrombolytics work quite well. The deficit of your loved one is not as severe. There's a reasonable chance they'll do okay. We are doing this complicated procedure that can have benefit, can have harm. Are you willing to participate in a study to generate sort of that kind of a conversation? Now, once it reaches NIH 12 kind of thing, the same conversation becomes much trickier.
Yeah.
I think, go ahead, Adnan.
No, I was sort of just talking about some of the comments that are there about comparison between stent retrievers versus aspiration. We just don't have enough numbers to be able to do that. These were majority first pass stent retrievers, so it's really hard to know that. In terms of technique for aspiration, I think the desire is to engulf the clot as much as is possible and then apply the aspiration so that the problem is that if the aspiration catheter is not directly in contact with the clot, the vessel between the two is going to collapse the moment you turn the aspiration on. And so the clot will stay on the other side. So ingest as much as possible, then apply aspiration. And at least, again, there's no clear data as to what the best technique is, but at least on benchtop, there is a difference if you leave the aspiration in place for 60 seconds compared to just go up there and immediately pull the catheter out. So because there's slow distal migration of the clot into the lumen of the aspiration catheter. And the more rightly sized you are, the more likely you are that you will get the whole thing rather than have distal embolization. But there is no specific technique that has been validated in terms of optimal performance.
Dr. Siddiqui, do you cross your Mevo clots when you're using the 35, 45, and 55 with a wire that sort of matches your catheter, meaning instead of using small wires like we did in the past, using an Aristotle 18 or 24 to reduce ledge and to help with that engulfment concept that you just mentioned?
Absolutely, Bree. That's exactly what I do. I use 24 as my favorite wire. I'm not quite that big a fan of the 35. I think that is just a little too much for me, but 24 is very torqueable and really allows you to get access to M2, M3, M4. And then when you pull it back, so I try not to cross the clot with the 24, but I like to keep it right at the face. And then when I am at the face, then I push my aspiration catheter as I quickly retrieve the wire, hoping that that creates a little bit of a local vacuum and then connect it to the pump. So that's exactly what I do as you're suggesting.
Yeah, that's, I think the wire, in addition to the catheters being sort of the newest generation being so helpful in getting to these distal clots by being longer, by being more flexible, by having more surface area, I think using these wires to our advantage has also been helpful in pushing the technology forward.
I completely agree. I think there's an interesting question here for Mayank, which is in Escape Mevo, there was no significant difference in final infarct volume between EVT and medical therapy. Do you believe this suggests that these patients were treated too late, negating the potential benefit, or is some other reason?
Like the one thing to mention is that on the baseline CT scan, baseline CT perfusion, baseline collaterals, there weren't that many surprises. We saw what we saw, what we expected to see. Aspects was 9 or so. There was always a mismatch in majority of the patients who had perfusion imaging, the patients who had collaterals, that very often decent collaterals kind of thing. So that's sort of one part. The second part is the fact that there's no difference in infarct volume sort of matches the part that there's no difference in clinical outcome. So it would have been a surprise if there was a difference in infarct volume with no difference in clinical outcome. The third part is that I'm really sort of against this idea of what we call final infarct volume. I'm against the use of the term final, because I don't think we understand that well enough. And I think infarct continue to evolve and change. And I'm sort of working very hard to better quantify this idea of selective tissue loss, selective neuronal loss. And we have this tendency to draw lines along what we see on diffusion or hyperdensity and sort of put it all together and measure 31 cc or something. But I do think that 31 cc could be pan necrosis, could be partially necrosis, et cetera, gray matter, white matter, so on and so forth. One of the things I teach sort of the residents is this idea of that the gray matter is your cell phones and white matter is your cell phone tower. So if your cell phone goes away, you can borrow the neighbor's cell phone and make a call. If the cell phone tower is gone, then you cannot borrow someone's phone. So brain plasticity doesn't happen if the white matter is hit. But very often when we do calculate final infarct volume, we don't adequately take into account the degree of white matter damage, because it's not easy to do, especially on CT scan. It's much easier to do an MR, but even on MR, the way that we draw these lines to measure it sort of thing. So I do think FIV data, final infarct volume data, has to be taken with a pinch of salt as we currently stand. We are starting a study, which we have just started, is we are doing 5 MR sequentially after the stroke, so that we can sort of figure out what happens to infarcts and so on and so forth. But the other thing, more importantly, that the reason we are doing the study is finding out therapeutic opportunities. What are the opportunities for therapy after EVT that we are currently unaware of, and whether we can predict that this event is about to happen and look for imaging biomarkers to be able to sort of say, okay, this is what is likely to happen next. How can we stop that from happening? Quickly repair the blood-brain barrier or whatever it is, sort of thing. So but I've sort of given away multiple different points in this answer, putting it all together. But the short answer is don't pay too much attention to FIV.
Thank you both so much.
Well, we're over the hour here. I want to give you guys both a kind of an opportunity to give final thoughts on, where we're headed with the future of medium and distal vessel occlusions. What is your kind of last word on this topic, and what you would like to see in the future in future trials, or maybe even some practical advice for the operating interventionalists out there.
Age for beauty.
So I'm older than you, but Okay, I'll go first. So here's the thing. So one is I'm super, super happy with the level of interest, the level of commitment in our community, the level of trials being discussed. And if you go back 10, 15 years, and Bree, you were probably in high school at that time, there was not that level of interest in the general idea of randomized trial, level 1 evidence, so on and so forth in our field. And that is in some ways extremely satisfying to people. And I can say on Adnan's behalf, on people like Adnan and me, where we feel like we've been part of that journey to make this sort of into into our very existence, this idea of evidence-based medicine. So that is really exciting, and that the fact that there are 5 trials being discussed, et cetera, and we were arguing about the fine points of trial design and all. So that's on the positive side kind of thing. On the negative side, I would only say 2 things, which I've already said 5 times during the last 1 hour, is big sample size, commitment to randomize all eligible patients.
I think very well said. I really cannot agree more with Mayank. It's really exciting to be in a field like ours where we are now prospectively studying these very difficult questions and coming up with answers. Now, we had a great streak from 2015 till 2025 with just positive trial after positive trial. So now this is a reality check, but we need to do the same as we did in 2013 with the original negative stroke trials to say, how can we design something that is better, that is more sensitive, be it a better scale as suggested with the Cosmos scale by Mayank, or be it with a different technique such as distals with the tiger retriever, or with the imperative clear trial. I don't know what they're going to call it. I hope they have a really cool name for it, but I'm not sure what the name is going to be. But I think that would be for aspiration, because these are legitimate questions which are raised, regardless of cherry picking or not enrolling every consecutive patient. I think the results are quite sobering from these trials, and they suggest that we need to fundamentally think about a different approach, and be it a better stent retriever or be it aspiration as the primary modality are 2 logical, reasonable things. And I'm so really excited that Imperative is going to take this on, and we'll see where the results land. But I do agree that this is an exciting time to be in the field where we are actively changing guidelines and changing outcomes and bringing better practices into the real world.
Very, very well said, both of you. I want to thank both of you guys. Bree, do you have any last final thoughts?
Oh, this was wonderful. Thank you both. It's just an honor to have you both here, and thanks for making time for us.
Absolutely. Mayank, thank you for your participation. Not an easy trial to run, but thank you for fighting the good fight. Dr. Siddiqui, thank you for your wisdom and thoughts. We're very excited to see what Imperative Care has in store for us. Obviously, a huge topic. Thank you for everyone who participated and offered questions. We didn't get to all of them, but I hope this was educational as anything, we have more questions and hopefully more to answer. So thank you, everyone, and have a great night.